Hello, please.
Hello,
Good afternoon.
hello, good afternoon, everyone.
Yeah, good afternoon.
Please, can you hear me? Oh, can
Yes,
everyone hear me?
yeah, we can hear you all right, please.
Okay, so I think it's 2:10 now. You can go ahead. Whilst I believe others will join us as we continue. So, good afternoon once again, distinguished colleagues and participants. On behalf of the West African Center for Climate and Health Innovation and Resilience, and the Climate and Health Evaluation for Adaptive Resilience Program, I warmly welcome you to today's session of the 2025 Climate and Health Research Webinar Series. Our theme for this particular session is Building Climate Resilient Health Systems in Resource-Constrained Settings. This is an urgent and timely discussion as climate change continues to pose complex challenges to health systems globally, particularly in our region, West Africa, where resource limitations compound the risks to vulnerable populations. And I'm sure we all know that climate change is now recognized as a health crisis, not just an environmental one. And regions like West Africa are faced with compounding vulnerabilities like weak health systems, limited infrastructure, poverty, and climate-sensitive disease burdens. Building resilient health systems is central to climate adaptation and sustainable development. I'll be guiding with this session, I'll be guiding as a moderator today. And my name is Dr. Labis Digbe from the Operational and Environmental Health Unit of the Ghana Health Service. We are honored to have our presenter, Dr. Rudolf Abugnaba-Abanga. I hope I got the name right.
Yeah, it's fine.
Deputy Chief Nutrition Officer with the Presbyterian Church of Ghana Health Services. Dr. Abanga also serves as a co-chair of the Climate Resilient and Sustainable Health Systems Technical Working Group of Health Systems Global. He brings a wealth of experience in public health, health systems strengthening, and leadership in advancing climate resilient approaches to healthcare delivery in Ghana and beyond. We encourage all participants to actively engage, please ask questions and share insights as we work together to explore innovative strategies for building stronger climate resilient health systems in resource limited contexts. I will not take so much of your time. I'll go ahead and hand over to Dr. Abanga to take us through his presentation. Dr. Abanga, please, can you hear me?
Yes, I can hear you.
So please take over.
Yes, thank you very much. I hope you can see my screen.
Yes.
Yes, okay.
Yes, you can.
Yeah, yeah, it's on full screen now, right?
Yes.
All right, thank you very much. So today we will be talking about building climate resilient health systems in low resource setting or resource constraint settings. I am hoping that largely, I think our audience are Ghanaians, and I'm hoping that we're going to do justice to this topic. And I'm very grateful to have the Ghana Health Services as part of this. So basically, I try to talk about why climate resilient health systems matter. Our chair has already introduced us to that. And then briefly, we'll try to go to look at a number of international framework and tools that are available for undertaking this process. And then we would zoom into the Ghanaian context. We look at policy versus reality. And then I would further zoom into the work I did to look at some of the facilitators and barriers. And then after that, we would look at the way forward and then the what we call TIC mainstreaming approaches based on the work we did, I think the last 4 or 5 years in this area. Yes, so as we all already know, climate change. In fact, it's the biggest threat to global health and well-being. We know that, and that is established. Everybody believes it. And shockingly, we estimates suggest that 100 million people will be driven back to poverty by 2030 due to climate change. And interestingly, much of the reversal will be attributable to health, negative impacts of health. This is coming from the World Bank. And then again, like we all know, health service disruptions will definitely undermine universal health coverage. And climate change and then the extreme weather events. Climate change will lead to more extreme of increased frequency in extreme weather events. And this obviously would also impact the way our health services run. And then we cannot already achieve universal health coverage. So climate change basically adds additional burden to our health systems. And then economically, there's also an estimated that there will be US $200 billion loss of output in health and healthcare. This is by the World Economic Forum. And as you can guess, right, Africa is the least prepared, so you can be sure where these losses are coming. And then in Ghana specifically, I think that we all agree that there's an increase in extreme weather events due to climate change. And then also there will be the rise of climate-sensitive diseases. And then this will impact on our healthcare services and their ability to deal with this, especially in the poor and remote communities. Interestingly, health also accounts for 5% of global greenhouse gases emissions annually. So what this means is that we cannot just talk about adaptation, but the health systems itself must strive to make sure that it reduces some of the things or the waste that impact on our climate and then impacts on our health again. Now, I just want to take you through some of the nexus. A lot of people do not really get the nexus between climate change and health. And as you can see on my extreme left, I took this from the media, 3 News. I think you're all conversant with this. I think this is a ward. I hear it was a corona ward in a newly built hospital. It got flooded. So you go to the hospital, you want corona to help yourself, and then you are flooded. That is a classical example of what climate change can do. And then next to that, this is I think a delivery room somewhere, and you can see at the extreme and it's leaking. Just one storm, it's torn, it's leaking, and you can imagine if your wife or your sister is to be delivered and there's a rain in this situation, what's going to happen? Is she going to come back normal or not? Then you can see my picture there with less great hair, of course. When I was doing my field work about 3-4 years ago, I went into a community, and before I came back, it rained. I just couldn't pass. That is it. My vehicle couldn't pass. And then I was now wondering, in case there's a medical emergency and they have to pass through, what happens to this fellow? It's a story that we all need to think of, and it also tells us the multidisciplinary nature of climate change, and then how other sectors have to come into play to ensure that we become much more climate resilient. And then the last picture on my right, you all are also familiar with this story. It takes several years to train a medical doctor. And then you can imagine the fellow goes to work and then comes back and then is gone. And the state would have lost all the resources, would have lost all the specialists or whatever that fellow can give to us. So that is an example of the nexus. And this is also another example of the nexus. To my left, this is far away, I think in Madagascar. There's a rainstorm, and then you can clearly see the health facility is ripped off. I took it from the WHO. It's ripped off. So now people, if they are in remote communities and they have to come to this particular health facility to receive at least emergency care, what happens? So you can now appreciate the nexus and the importance of health systems. And then on to my right, this I also took it during my work. And then you can see that it's an electricity pole that is bent. I cannot tell the number of health facilities that this electricity pole supplies. But there's one thing that is very clear. We store our vaccines. There are some equipments that are electricity dependent. And then there are some other medicines that are also dependent on refrigeration. So it tells you what will happen within that period. And then again, I know vaccines are, especially for children, are on a schedule. So what happens then? So these are some of the impacts and then the nexus between climate change and health that we talk about. Now, there are a number of definitions, but I stick to the WHO ones. And then I'll just touch on the first one. They are very similar, whether it is low carbon or it's climate resilient, environmental sustainable healthcare systems, facilities. But the WHO says that a climate resilient health system is one that is capable to anticipate, respond to, cope with, recover from, and adapt to climate-related shocks and stress to bring sustained improvements in population health despite an unstable climate. That's the definition by the WHO in 2015. Fast forward, we have moved a bit to low carbon health systems, but practically they are about the same, I think so. So I'll move on to the next slide. There are a number of frameworks internationally that and tools that we can use to assess and that will help us to build climate resilient health systems. So first of all, we are in the African context. This is coming from the African CDC, which I think was released in July 2025. That is the blueprint for the AU. And then they have a climate change and health strategic framework. They use One Health approaches. I'm sure a lot of you know what One Health approach is. It is the health of the people and the planet. So whatever we are thinking about, then we look at animal health, we look at plant health, and we look at health of people all together. So it talks about a coordinated strategy to enhance climate resilient health systems. But it is basically integrating a number of frameworks from the WHO and other places to come out to this. But this is a framework, it's not a tool. So it means that if you have it, then you have to find out how to move on based on the framework. So it's more or less a guidance document. Now, there is the next one, basically by PAHO, Pan American Health Organization and the World Health Organization. First, I think a couple of years back, a couple of years ago, they had what we call the Hospital Safety Index. Now, the Hospital Safety Index, it's a guide and a tool that helps us climate-proof our health institutions and facilities. But I must emphasize that this is just meant for health facilities, just to climate-proof, to show that they are climate resilient. So what happens is that you are using it to check specific health facilities to see whether they can be resilient to extreme weather events and the rest. But again, like I told you much earlier on, you'd realize that beyond a health facility standing to render the care that we have to during difficult times or at all times or in a rapidly changing climate, the health sector must also do a lot to ensure that they also have green operations. So based on that, they move to what they call the Smart Hospital Toolkit. That is the most recent one. That integrates both the resilience part, the Hospital Safety Index, and other green and smart initiatives. This has got actually a lot of tools to deal with it, but the challenge has been that you really have to adapt them. It's not made for our region, but it has been extensively used in a lot of countries. I think over 1,000 health facilities have used it. It works very well. And then again, you always have to look at the national context, whether a government or a health service supports this or not. But it works very well. But it is, again, complex and needs adaptation. Now, the World Bank also have a framework which they call the diagnostic. I think it was released in 2018. It's been used in Madagascar extensively. And I think that this tool is also meant to just build climate resilience and then environmental sustainability. But it is focused towards World Bank projects, but it's also adaptable. In Madagascar, I think it was used for assessing their health systems and putting in place strategies for them to become climate resilient and environmentally sustainable. All these are found online and you can get them to do further reading if you have interest in them. Now, there's also a big initiative. I think one of the most popular initiatives with tools that have been tested comprehensively across all regions. It's called the Global Green and Healthy Hospitals Initiative. And then they also have a model. They have 10 goals that falls around leadership, chemicals, waste, energy, water, transportation, food, pharmaceuticals, building, and purchasing. So what this tool also does is that it first a framework, and they have very extensive tools. First, you need to register as a member, and then they will introduce you to these tools, and then they have been tested. A lot of hospitals have used this to become climate resilient and environmentally sustainable. But I think the strength of this more is on environmental sustainability. So this is also available, and then you can check their website is there. You can join, and then they can support you build climate resilient health systems. Now I'll focus on the WHO because I have the understanding that Ghana is leaning towards the WHO frameworks, and then the WHO has a conceptual framework for building climate resilient health systems, and it's simple. What it says is that if you decrease vulnerability and you increase capacity of health facilities, you have improved choices and opportunities, and that will enable your health systems or health facilities to be able to resilient to climate, and they'll be environmentally sustainable, and they can recover when there are extreme weather events. Now, the WHO, why I also seem to like it so much is because I work with the tools a lot. And then again, it's a system-wide thing. So you see, they have 10 climate resilience components. For the sake of time, I can't read through. But what happens is that it builds on the 6 building blocks of every health systems. That is the leadership, health workforce, health information system, essential medical products, technologies, service delivery, and financing. So this builds, it's a system-wide approach, and it builds on it. So it tells you components or what you need to do or interventions you need to put in place to ensure that all these 6 building blocks are climate resilient and environmentally sustainable. Now, they also have a kind of checklist. I must emphasize that all these things need adaptation. They are difficult for the local settings. You need to look at them, you need to adapt them a bit such that they can fit in very well, but they are fairly compatible with our systems, even if you don't do extensive adaptation. So to my right, they have further produced a tool for measuring the climate resilience of health systems. So you can use this to measure the climate resilience of health systems at all levels, national, regional, district, and then you are able to fairly judge whether health systems are climate resilient or not. Now, specifically, you all agree that for a lot of people that are not health inclined, they find it difficult to see that the health facilities, or they just think the health systems are health facilities. But health facilities are a part of health systems, especially at the primary healthcare level. So the WHO has another framework and a checklist for assessing the climate resilience and environmental sustainability of health facilities. So for them, this framework only operationalizes the one parts of the framework for health systems. And then they say for health facilities, we must look at the health workforce, water, sanitation, hygiene, and healthcare waste, energy, and then infrastructure, technology, and products. So you can see there's a whole checklist that it's meant to do this, which you can easily apply. I've applied them in our context with very minimal adaptation. It works well. It gives us an idea as to how to move around or how our health facilities are resilient or environmentally sustainable. Now, I want to touch a bit on environmental sustainability, and then again, or you can find out that in the operation of our health systems or health facilities, we generate a lot of waste, or we generate gases, greenhouse gases in our operations. So there are typically 3 types, which we say they are scope 1, scope 2, scope 3. And then first of all, for scope 1, as you can see on the screen, these are things that are within our control most of the times. Waste reduction, recycling, fossil fuel use, reduce unnecessary travel, and then anesthetic products and use reusable medical devices. These are things that we have the choice to do. And then that is very direct, we can control them. Then indirect, we have scope 2. And then they say, well, you can reduce your energy use, especially in Ghana here. You notice that our energy is coming from the grid. So we don't have, like, we don't have a choice, whether it's coal powered or what powered. That's what, but at least we have a choice as to how we can use our energy. I've seen health facilities where people wake up and then at the end of the day, they don't even put off the lights, or even our individual offices. The lights are there, the outside lights are there. And then people just use water. It's heated because they are not paying for it. But all this has an environmental cost. And then again, what kind of equipments are we using? Are we using very efficient equipment, or we are using green equipment? Then the biggest, scope 3, that is about 71% of the greenhouse gas emissions. It's indirect, and that is our supply chain. Obviously, you can find out that how our workforce is also traveling. How do we dispose our waste? That's very important. And then energy comes in here. But most importantly, is procurement. We do procure a lot of things. What kind of things are we procuring? And then what kind of equipments are we doing? Are we doing green procurement? There's something called green procurement. I know that the healthcare waste policy for Ghana, I think it was around 2020 or so, it's emphasizing on green procurement. Is that what we actually do? So you can see that we have the opportunity to do a lot more there, and then we can become environmentally sustainable. Now, I specifically zoom on Ghana now. And then, as you can see, Ghana, it's a bit progressive. As you can see, these are all national level policies. And I tell you, in all these policies, I am still counting. Health is always a priority area. Climate resilient health systems is a priority area. Human health is a priority area. So we don't lack policies. And I think we're one of the first to mainstream climate change and health into our health systems medium-term development plans. I think that was in 2010 and 2014. So we really don't lack policies, as you all know already. So counting, I can add up to 10. And then so generally when it comes to policies, I think we are a bit secure. But what is the reality? Unfortunately, I also come across this a lot. This is waste to my extreme left on the top. That is waste. And that is how we dispose it. We just burn and we release it. In some cases, they are openly burnt. These are in Ghana. And then you can see that at a point, we look at the way waste is being disposed in a health facility in Ghana here. And then this particular plastic, I was walking on the mountain, and I came across it. It's coming from a hospital. We said that, well, we'll give it to you to be able to take your drugs home. What happens then? I find it. So in Ghana, you know that almost everybody attends the health facility once in a year. So we have 30 million people, 30 million plastics. Do we know where they are being disposed? Can we begin to become deliberate about this? And when I say deliberate, what does it mean? If you allow people to come with their own bags and have medicines, I think it won't prevent anybody from getting their medicine. So these are some of the things that we can do for environmental sustainability. It is not just about big technology. We can do a lot more things. And then this beautiful health facility, 800 kilometers from the capital, when I saw it, I was very impressed. But you can see below there are corrugations. And let me tell you something. If it rains, any staff that's trapped there cannot come out. Anybody that needs emergency care cannot get there. So it tells you that what decision went into this. So we need to begin to think of how we even do all these things, and just a simple engagement to kind of get appropriate land to site this would have saved everybody this headache. I already kind of told you about this picture, the electricity pole. And then this is SMC. The health staff is there. You can see the whole place is water. And I'm sure after this experience, the health staff is never going to go back there when it rains. And children are going to miss their dosages and other things. So we can really plan to avoid this. Must the health staff necessarily be there? Are there schools there? Are there community-based volunteers there? Can we actually train them to do some of these things instead of we insisting health staff must go there and the rest? And then lastly, you can also find out that that is a health facility, the lower corner on the right, and that is people's records. Just because of wind, it's opened up, and then people's records have been destroyed. And I wonder when they come back, what they are going to do or how we are going to start all over. So these are the petty things that when it comes to climate resilience and environmental sustainability, we can think about it. And for electricity, can we also begin to procure solar products that we are using? And then we are sure that even though we don't have control over the grid, when the lights go out, we are able to kind of keep our vaccines and other medical products and supplies that are refrigeration dependent safe until we get the grid back. Now, based on our work, we tried to see how using the WHO tools to see how the WHO framework is suitable for our primary healthcare systems, and then generally we found out that most primary healthcare managers thought that the framework was very suitable for primary healthcare. And then the managers also identified with the framework and they thought that, look, this is very, very, very good and it can enhance their health capacity. And then again, there was consensus that, look, considering what we are seeing, we are already feeling the impacts of climate change, the gaps and everything. So that tension for change, really, if the health systems introduce this, is going to pick up by itself. Now we come to extreme barriers. And then number one on the line is policy and incentives. And then focusing on policy, you all agree that the health systems is heavily regulated. We work with policy, protocols, and guidelines. And then you can be sure that if PAC is not guided by these climate resilient operations, they are not going to do anything about it. And obviously, in our system, we always talk about cost. Cost, it's a big thing. We must always, we already don't have the money to run our normal health systems, but adding this might be cost. But from the pictures I showed you earlier on, cost might not necessarily always be the problem. It's just about the guidance and the rest. The big time things might be cost when it comes to procurement, but I think it doesn't cost anything to decide not to give your medications in single-use plastics. And then peer pressure, it's this is coming from the context of system. For PACs, we run system. You go to a region, there are a number of PACs or districts, and then they do things in uniform, reviews, the same standards, the same prevention modes, the same priorities. So the other thing is that, well, when we have it as a system, then we are beginning or we'll be able to get a lot more primary healthcare systems to do it. And obviously, they are not exposed to networks and connected to where they can get these informations to get them. So these are the key barriers that we find out in our setting as Ghana. So policy, it's the main one. And I think that if we mainstream our policy very well, then we are able to at least kickstart this thing about climate resilience and environmental sustainability. Clearly, policy coordination is a challenge. So I took this master plan. You can see health, priority, very well documented. They even provided a mainstreaming framework for the health systems, how they can mainstream it into climate change, into their operations. Now, it is a trend, of course, all our policies, even the most latest ones. So when I just do a check, health, I find close to 400 words on health somehow. Then I come to our latest national health policy and I put there climate. I don't find anything on climate. Of course, you find things on environment and rest, but I don't find anything on climate. So it tells you how poorly we coordinate this policy. And then even if at the national level it's poorly coordinated, then you can imagine at the primary healthcare or district or regional level how it would be like. So this is our main beam. And then again, I just show you. You had seen this picture earlier on, but on my left, you see a very newly constructed structure. That was a wash facility by an NGO, and then they put in place a water system, they put in place whatever, and then they built new toilets, and like fine, it was very good. There was running water, there were now very good toilets and everything. Just behind it, where this delivery room is, you can see that the roof is gone. And this is the effect. So what is the effect of investing in this to enhance maternal health? And then you really have our leaking delivery room. So you see there's a poor stakeholder collaboration between state and non-state actors. And this is something we can really do very well, because I'm sure they went through the health systems. If they had discussed it well, they would have found a much more suitable way of doing this. So this is something that I want you to know. So what do? We obviously have to integrate climate change adaptation and mitigation into health systems, facility policies, program of work, and put in place accountability mechanism. This is what we call take mainstreaming. Because we realize that in the health systems, if you don't do this, then especially at the primary healthcare level, they are not accountable to it. It's not also part of policy. So they don't even need to do it, even though they feel it. They just manage and it's business as usual. So it's a concept we call take mainstreaming. And then what are some of the prerequisites? We need awareness, political commitment, and community engagement. And then the national health system policies, of course, we should get them mainstreamed with climate change and health initiatives. And then the local government, it's very, very important to this. And then we also see the local government health development plans also very important. And then community health systems and plans. Capacity building is a very important thing because the staff need to understand this. It looks a bit abstract, but it's something they live with every day, and it's something that they can really work on. But we need to build their capacity to understand the nexus between climate change and health. Now, way forward, we tried to co-create. This is 1.0. We are developing, and hopefully next year we'll validate this through another program. And then we tried to come out with a win-win situation, a situation where even though much of our protocols and policies do not mainstream this climate resilience and environmental sustainability or low carbon actions, we try to find out what can we do now to ensure that at least we can begin to add environmental considerations until a time when our policies are fully mainstreamed with climate considerations. So we together with these healthcare facility managers and then DHMTs, we identified for subnational integration, that is at the primary healthcare level. The levers is the district health medium-term development plans, and then routine reviews, and then the legally mandated bodies, the district health committee, community health management committees, and at least CHIPS is also a strength, the close to client services, that we can leverage on this for now. And how do we do that? First, if we can get the district health committee and other actors, we oriented them to appreciate it. And then we get it mainstreamed into the district health medium-term development plans. Once we get it mainstream there, then we can begin to orientate staff. We can apply this WHO checklist. First, we don't need to even adapt them. Let's apply them, and with time, we can adapt them to suit our situations. Then we can develop climate resilient improvement plans. Then we can mainstream into the healthcare facilities annual work plans. And then we can also mainstream into the performance reviews of health systems. And what does this do in the first place? We talked about cost. First of all, you notice that the district assemblies or the local government authorities are largely responsible for the construction of chips and other things. So we can say that, okay, first, if we get these people to understand and appreciate it, even in the construction of our health facilities, the new ones, what can happen is that they can begin to add these climate considerations, at least in the infrastructure. And then beyond that, then there are little things that we can also do as health system actors or health system managers, because it is captured in our medium-term, district health medium-term development plans and the rest. And number two, importantly, there are a number of NGOs, a number of non-state actors that come in to test things or run interventions in districts. Then we can begin to say, per this district, per our medium-term development strategies and plans, you must show us your climate considerations in your operations. So you see, we begin to force other actors that benefit so much from implementing things in the districts. to also bring climate considerations. And in that process, we are also leveraging resources for climate action within our primary healthcare system. So this is 1.0 is basic. We are further improving it, and hopefully next year we might validate it if things work out as we plan. Now, I want to give an example of take mainstreaming versus the horizontal ones that we have. I used the technical guidelines for integrating disease surveillance and response in Ghana. I think this was in 2002. And then I take the national health policy in 2020, and then it is clear. It's captured there. Then now I go down to the Health Information Management System of Standard Operation Procedures, 4th edition in 2020. It is captured there. It's mainstream. So this is an example of what we call thick mainstreaming when it comes to climate action. So you see that no matter what we do, because it is captured from the national, boiling down to the, or trickling down to the primary healthcare level, they don't have a choice. They have to be accountable for this. So if we can replicate some of these things when it comes to climate action, then cost doesn't become necessarily the biggest barrier. And then policy-wise, people are covered. And then what's going to happen is that people are going to innovate. I can tell you they're already innovating. And people are going to be confident to do some of these things. And then we improve bottom-up approaches. So I think that this is the end of my presentation. There's one more slide. It's just a point, but I can bring it out, but I'll still wait for your questions and the rest, and then we can move on. I don't need to talk about this. I'll take questions and clarifications, and these are broad reflection questions that you can go, and that is what are other context-specific barriers into mainstreaming climate action or climate change adaptation mitigation to your health systems, and then what are other PHC system entry points in Ghana for mainstream or in your locality for mainstreaming climate change adaptation and mitigation. So I'll stop here and then we can move on with the discussion. Thank you.
Thank you so much, Dr. Abanga. Thank you. Please, any question, you can raise your hand or drop the question in the chat box, please. Hello.
Maybe whilst people are thinking about their question, sorry, let me raise my hand.
Okay.
Rudolf, thank you for the wonderful presentation. And I like a lot of the things you said. And for me also, I think that mostly it's important that you emphasize that health systems are not health facilities, because people generally neglect put health facilities at the forefront whenever they hear about health systems. So to start off with, I wanted to understand from you, if from your work you've been able to identify some of the things Ghana or other African countries are doing regarding ensuring that we have a climate health resilient setup.
Okay. Yes, it's a big problem in the first place. In Africa, we do have from the last time I checked from the WHO, just 2 countries had kind of done any kind of assessment, at least from national to the health facility. That means the health system inclusive. But there are very big leaps in the last 2 years. I think Kenya, Malawi, Uganda, Egypt, they have begun the process of mainstreaming, and they even have strategic plans at the national level towards these things. Now I will focus on Ghana. It's amazing. I have seen a lot of things that people have done at the primary healthcare facility level. For example, I have seen a primary healthcare trying to innovate waste disposal. So they design a kind of like the they design, they dig, concrete it, and then they kind of, in their own way, they kind of bend, but it's closed somehow. So you have very minimal, but that is not scientifically proven. And then number two, I have also seen health facilities or primary healthcare systems or district directors of health services specifically begin to green their health facilities. So they are putting a lot of trees there to serve as windbreaks for storms and then to serve as cooling effects during the heat season. And then so these are some of the things. And then I have also seen district assemblies, and then together through NATMO, together develop emergency response plans. But these are always lying down. They don't implement them. They are more reactive than proactive. So even though the plans are there, they only wait, and then when there's a problem, for instance, when there was an outbreak of anthrax, they had to meet and rapidly just do something and get it done. And I think that is good. People are beginning, or districts are beginning to see, they feel it. So they are taking steps to do some of these things on their own. So I think that there's effort at the lower level, but it still remains a big problem. Even in Europe, I learned it's also a big problem. But they are talking about big technologies, and we can do a lot more, I think so, if we have the right policies and guidance.
Any other question, please? So, Doc, you mentioned that there are a number of policies that we have, but the reality is not encouraging. Can you explain what the gap is?
Yes. So from my understanding, our difficulty is how to translate policy to action. And I think that it's a general problem in Ghana. We all agree to that. Because when I take the master plan for Ghana for adaptation, they specifically put health there. They specifically put the strategies there. They've specifically even developed a kind of framework to help the health systems mainstream this into their operations. But you see that intent has not been translated into our health systems policies, and it has not been decentralized. So even at the national level, it's not translated. Then now, when it comes to the PEC, it's not translated. I think the CHIPS policy did a lot. The revised one did a lot in terms of infrastructure and those things. They did a lot. They tried to talk and the rest. But again, you would even notice that even with that, when you go to the assemblies, how many of the assemblies are actually building the recommended structure, putting in place all the things that we are? So the challenge is that we probably haven't learned to say that these are standards, and we haven't learned to say that it's either this way or you are not helping the situation. And like I told you, collaboration is a big thing, because when you look at climate change, it's beyond sectors, and even globally, you usually find the environmental ministry in charge of all these things. So first, at the national level, I think that it is proven that the health systems or the ministries of health and their institutions are not actively engaging in climate change processes, adaptation and mitigation processes into at the national level. For instance, I met a negotiator for Ghana at the COP, and then when we started to speak about health, the fellow said, but we're already doing health. And I said, what are you doing about health? But we are doing clean stoves, these cooking stoves. It is health, all right, because we have much more, But then I now had to explain to him that the health systems itself has to respond. They have to lead the response because they are impacted. And once they lead, then you can feel it more. So I think that those are the things. And like the picture I showed you about the NGO, beautiful structure, water system, everything. And then for women to use when they are in labor and the rest.
Mm.
They invest so much, but the key room is gone. It's leaking. This could have been discussed amongst
Yeah,
people and the rest.
yeah,
And then,
yeah.
so for me, it's about redirecting our investment. I think we have some level of investment, but can we coordinate it? And fortunately, the health sector is very influential at the primary healthcare level or at the district level. So if we begin to go that way, I think a lot more people will join us.
Okay, thank you so much. Please, our dear participants, we are waiting to hear from you as well.
Moderator, if maybe they are shy to talk, but I can also maybe we can invite
There's a
them
hand
to.
up, so there's a hand up,
Okay.
so
Okay, so let me stop sharing. Yes. I wanted to discuss the last questions I asked here.
Okay. So,
Okay.
okay, yes. Please, you can go ahead.
Oh yeah. So, Doc, thank you so much for the presentation. You've spoken about health systems. I want to find out the place of local communities in health systems, and then what the local communities can do in respect of supporting in this health system strengthening. Thank you.
Yeah, thank you. I think that you cannot talk about health systems without the community. The community is a very big integral part. And then, like I told you, CHIPS, so community health systems are the extension of our health systems. So you notice that CHIPS is close to client. And I gave you a very good example with a picture. A very beautiful CHIPS. That was a CHIPS, not even a health center. The picture I showed you. Very beautiful one. They had almost everything I thought of, incinerator, whatever. But it was built in Madiland. When it rains, the health staff cannot come out. The woman in labor cannot even get there. They are better off looking for another route because land. You go there, you ask for land, they'll give you the land they don't use because they are already feeling the impact of climate change. Probably they are not getting what they have to get during their harvest. Yes. So this could have been solved if communities were involved, especially with the community health management committees that are very critical. This could have been solved if they had been explained about, they had probably done these assessments together and see the realities. They could have solved it and have the health facility at a place where everybody can attend throughout the year. The health the service provider or the health workers can also attend throughout the year, and they too can also access it. So I think that the community is very important. We cannot speak health systems without the community. So if you are doing all these assessments, you notice that community, there are questions of communities that are kind of integral to it. I hope I've answered you well.
Hello,
Yes,
Mr. Prosper.
yes. Just to add that, so when you mentioned the community health management, you realize that we have it on paper, but when it comes to the realities, they are inactive. And so in the CHIPS concept system, you have it on paper that every CHIPS should be managed by, there should be a community health management committee. But these committees actually do not function as they should function because they are not remunerated and there's nothing, and sometimes they cannot just leave their means of livelihood to be doing these kinds of work when there's nothing to get from it. So to what extent do you think we should also deal with that situation? Thank you.
Yes, that's a difficult question, but I think that when you go to every community and then you ask them to prioritize what they want, possibly the first thing they will tell you is that we want a clinic, right? So they are motivated to ask for a clinic. How they are not motivated to run active community health management committees could be it could be still, I don't know, I can't tell, but I can think that, well, maybe we too are not approaching it in the right way. And then we are not also involving them appropriately. So these are things that we need to look at. But I think that if we really, not necessarily monetary motivation, but if we really engage them appropriately and engage the appropriate stakeholders, that is, if we do proper community entry, being sensitive about their needs and everything, and they begin to see the benefits of some of the things they do, I am sure that we are going to be able to get them a bit to be active. And then I also believe in the community health worker system. I honestly think that considering where we are now, either we must get to a lot of health staff to be everywhere, or we must begin to think of how we can integrate them somehow into the formal health system. But these are big policy issues that beyond me and you. But I think that if we really engage them from the climate angle, which is of interest to them. Remember, it's intersectoral, which is of interest to them. We should get them being active a bit.
Thank you, Doc.
Thank you.
Okay, so can we take maybe last question, and then Doc can take us through. Any other question? Okay, so I think, Doc, you can go ahead with your, is it last two questions? Your last,
yes.
Last slide, yes.
Yes, my last slide, yes. Maybe everybody will be forced to speak. How did I get here? Okay.
Yeah.
I can see some typos there, but don't mind. But I am happy to also hear from you some of the context-specific barriers to climate action with PhCs in your locality or in Ghana or region as a whole, or whatever work you have found yourself doing. And then number two, I am also happy if you can also identify any entry points in your locality that we can use to enhance climate resilient and environmentally sustainable health systems or healthcare facilities. So it's for discussion. So let's open up and then discuss this.
Okay, so we just have about, I think, 5 minutes for discussion. So it's open. But kindly raise your hand, then you can be given the chance to speak. Hello.
Our participants are they're shy. Yeah. If they are too shy.
So can it be like, can it maybe reflect on it at home? I mean,
yeah, it's possible, but I can see
share with you.
Yes, Prosper has raised the hand again. Prosper.
Okay,
yeah.
Prosper.
Okay, so I don't know if I understood the first question right, but then I'm looking at, for instance, at the chief compound level. We train our health personnel they still have the mentality of clinical different approaches to health. And so at the facility level, if we are to add a climate dimension to whatever they do, it is likely to see it as a peripheral activity that they may not pay serious attention to it. That's how I see. So that would be a challenge. That would be a barrier. That these things are meant for the environmentalists and not for us clinicians. Whichever form that they have to perform, like whichever responsibilities they have to do at that level.
Yeah, I agree with you. I agree. And those are the things about mainstreaming. If you probably are training, orientating people in chips and add the environmental dimension, I think that's perfect. I agree with you perfectly.
Please, any other contribution?
Thomas is ready.
Okay.
Thomas, please go ahead.
Yes, good
afternoon, Doc. Thank you for your presentation. Hello, I hope you can hear me.
Yes, please.
Yes, I am trying to contribute to the first question.
Okay.
I'm hearing from what Doctor presented on some of the policies and how they are trickled down to the community level based on Prosper's question. And to what Prosper has just mentioned, I think it is true. But I want to believe, or I want to agree that one of our predicaments, some of the things we are not getting right, is the fact that the government itself is not paying key attention. So that could be a barrier. I am saying this because we have so many qualified personnel sitting at home, not necessarily nurses, but in the area of climate change, environmental science, and who are also into health, but they are not employed. Why don't we start thinking about how to get these things into policy so that such individuals are incorporated into the system, so that coming back to the community level, they are able to play that role to augment the health sector? I think that is what I am seeing to also be the problem or the barriers that are preventing improvement in that sector. Thank you.
Thank you, Prosper.
Thank you.
Thomas.
Thank you, Thomas. Thank you. Thank you, Thomas. Any other? Can we take a last contribution? But Doc, do you think limited early warning systems and surveillance can also be a challenge?
Yes, I think that because we
have limited data, we really have to look at our data and our surveillance system when it comes to climate change.
That's correct. If we are building a climate resilient health system, all these things are they are part of it. Into all the frameworks we talk about, early warning systems and the rest. And then, so if we can also work on that, then it makes it interesting. And then I think I've also had perspective from PAC managers where they think that, look, some of these things, if we implement them and we begin to see the benefits, then people are themselves motivated to keep on doing them because it helps their work, it helps themselves and the rest.
Exactly. Because that's one of our challenges at Ghana ourselves, data. So we are really working on that so that at least it can also help with some of these challenges. Okay. So any other contribution? Our time is up. We just have about 2 minutes to go.
I had my hand raised.
I didn't see. Sorry, I didn't see.
No worries.
I
wanted to add to your last contribution about data. And from my experience with the health system, if health services are taking clear data points for some of the things, then it motivates, it cascades through the national, regional, and then the district level for them to also implement things that would ensure that they get a data point for that. So there are gaps in data, and until they start demanding data for some of the outcomes for the frameworks that are available, we won't see a lot of things. And I also worry because you remember just this week, you mentioned in your introduction that a lot of people are aware about climate change. But just this week, one announcement from a world leader has put a lot of skepticism in terms of whether it exists or whether it's a hoax. So I don't know if you're able to react to this.
Yes, it's all about science. I didn't even take it from that context. He also icked my thinking, to question some of the things we do. But I then asked myself 2 questions. Is it real? Do we feel it? Maybe he's a rich man. He doesn't feel it. So it's skeptical about it. But let's come back to Kintampo. Even our farmers, do they feel it? Are we beginning to see resistant strains of malaria? Are we beginning to see new diseases? Or are we beginning to see emergence of diseases that had already been kind of eliminated or something? So for me, it is real. So we, as a country, I think, have to begin to prioritize. And importantly, as citizens, if climate change is affecting us, can we begin to have a national discourse on it like the way we have a discourse on roads, water, and the rest? Can we begin to have a discourse on it? And then if we think that it is a mandate, or we owe, government feel that they owe their people roads, I think that they also owe them protection, and protection is beyond just security. They owe them support for adaptation, and then mitigation to make sure that their health is also improved. So I think that that is temporal. That's one person's view. A fellow person doesn't believe in science, but I think science improves. Science tells us that it's real.
Okay. So I think we can end here. Before we end, I just want to give a brief, give highlights of what you presented. And I must say it's an excellent presentation. I really like it. First, you touched on the need for climate resilient and environmentally sustainable health system. And then you took us through some strategic framework. I think you focused more on the WHO as well. Then you also spoke about the carbon footprint of health systems, then the national climate agenda versus realities. Then you took us through some of the extreme barriers. And of course, we had some discussions on that as well. Then the way forward. So I think this is just the key highlights. You touch on a number of things. I don't want to take so much time. So I just I'm just focusing on these key highlights. So I would like to thank you so much, Doc, for this excellent presentation. And I also want to thank all our participants for your contributions and your insights. And in fact, we are looking forward to a continued collaboration because I can see that we have a lot of work to do. The Presbyterian Health Services, our international partners, and all of us, we have a lot of work to do. So I think this will encourage us to continue with our collaborations. Thank you so much. Thank you. Doc, do you have any final take homes, or you're fine?
Yeah, thank you. Just to say thank you to everyone, and thank you, Dr. Digwa, for your time, and thank you for the participants, and thank you, Navrongo Health, Kintampo Health Research Center, for this opportunity. And then I'm also looking forward to further collaborations. Feel free to approach me anytime, whether it's from the health service or it's from. I am open to any future collaborations, or if there are jobs you think that can be of help, I am open to all that. Thank you so much, and have a nice evening.
Thank you. Okay.
Thank you.